Hello. Hello. Let's get started. So we get started on time and finish on time. If you could take your seats, that would be great. My name is Mike Cohen. I'm from the University of North Carolina at Chapel Hill. I want to make sure you're in the right place, like an airport kind of thing. You're on the flight that's going to talk about HIV and STDs. And we have a very distinguished panel of speakers. My co-moderator is the Director of STIs, HIV, and Hepatitis for the country of Brazil, Adele Benzekin, and she will introduce the speakers and make comments of her own as she chooses. She also speaks French, so she will give bilingual comments.
Bonjour, mesdames et messieurs.
Bonjour. Adele, please. Bonjour. So the thing about this session that's interesting, for Adele and I were speaking about this, and Connie Salem, who's on the stage, those of us who are over about 40 years old, maybe 50, most of us started out working on sexually transmitted diseases. Before there was HIV, we still had a really big problem with diseases that were really serious, STDs, now called STIs. When HIV surfaced, only a short time after the infection surfaced and the disease surfaced, we came to realize that HIV was yet another sexually transmitted disease. And of course, over time, it was proven that probably at least 70% of HIV is sexually transmitted. So in the late 80s and early 90s, the only way to deal with HIV was, in fact, to treat STD. That was, condoms try to invoke behavior change, but a real focus on STDs. And for those who were not alive in the 90s, there were many, many clinical trials devoted to demonstrate that the treatment of an STD could, in fact, reduce the transmission of HIV, because it came to be known that HIV transmission was amplified and enhanced by STDs. At this meeting, several presentations further emphasized the enhanced transmission of HIV by STDs. And in fact, the science has gotten better and better to the extent that the kind of virological changes that occur when STDs are present are recognized now. Also, the STDs evoke particular cytokines and changes in flora that are recognized as cofactors that facilitate the transmission of HIV. But going backwards, in the 90s, all the attempts to use the treatment of STDs to deal with HIVs didn't work out. And the reason they didn't work out is because it's a high degree of difficulty. You have to treat just the right disease at just the right time with just the right drugs, in the right dosages, and so on and so forth. My colleague, Dr. Salem, spent a large part of her lifetime trying to realize the success of treatment of STDs for the benefit of HIV. And of course, other methods came along that allowed us to deal a little bit differently with the HIV epidemic. And STDs lost their place in our world. But they're back, and this is like back to the future. That's how I think of it. STDs never went away. STDs didn't go away. They themselves caused terrible calamities. STDs, which are very readily transmitted, much more readily for the most part than HIV, serve as biomarkers of behaviors that deserve attention, and in some places deserve urgent attention in order to prevent HIV transmission. And as we use more and more antivirals and pre-exposure prophylaxis for prevention of HIV and do more testing for STDs, we see more clearly the magnitude and scope of the STD epidemic. So our symposium today is really straightforward. It's to shine a light on the STDs and bring the field back to where it started, because it's a really important topic. So we're going to have speakers about epidemiology, about details of transmission, and about prevention activities that bring us back to where we started in many ways, and an important beginning point. So I think Adele will introduce the first speaker.
So on va commencer. The first speaker will be Darin Russell from Australia. Darin is the Director of Sexual Health in Queen's Hospital in North Queensland, Australia. He has appointment as Society Professor at James Cook in Melbourne University. He is the chair of the HIV Foundation Queensland and has been a former president of the Australian Federation of AIDS Organization. And he's also the chief investigator on the Key PrEP study, which is rolling our PrEP at high-risk people in Queensland. And his recent research Interests include the elimination of HIV and hepatitis C infections. Darin, 10 minutes, please.
Okay. Thank you very much. I've been asked to present on the epidemiology of STIs in the HIV and AIDS era in 10 minutes. So I will attempt to do that, but please bear with me if I leave quite a lot of things out. No conflicts of interest for this particular talk. I think it's important when we're thinking about sexually transmitted infections that it's the important thing to realize is you only find what you look for. And generally, compared to HIV, there are poorer testing and notification systems for STIs, particularly in developing countries. And many countries have no surveillance systems whatsoever for some of the STIs. And where the data exists, it can be patchy or not current. And really, STIs have always been the poor cousins of HIV. HIV's done epidemiology much better, generally speaking. This slide has just come from the Lancet Infectious Diseases website. It's just been released, and it gives the incident cases in millions for chlamydia, gonorrhea, syphilis and trichomonas around the world in the various WHO regions. You'll note, though, that the most current data we have is for 2012. So that just shows again that we often don't have the best up-to-date data when it comes to epidemiology. I also think it's important we take a long-term view, and Mike Cohen has elegantly stated that. If we go back to the bad old days in the United Kingdom with gonorrhea, if you look in the 1960s and 70s, the swinging 60s and 70s, rates of gonorrhea, and these are actual numbers of diagnoses, not rates, were very much higher than what they are now, and yet we're having a panic about gonorrhea now. There have been historically very high rates, particularly during wars and times of social upheaval. And this is a common theme when we're looking at sexually transmitted infections. It's also important, I think, and Mike spoke about this again, the damage that sexually transmitted infections have caused. When we look at mortality rates for syphilis prior to the introduction of penicillin, they were higher than what we saw in the AIDS crisis in the 1980s and early 90s. So these infections have been horrendous, and they've been perhaps more common in the past than what we have now. And I think it's important to keep that in perspective when we see rises nowadays. However, I don't want to downplay the rises that we've seen, and these are predominantly data in the MSM, homosexually active male population, in the USA, Canada, Germany and Sweden, and wherever you look, you see rises that have really started to occur in the 2007, but even going back earlier than that, you'll start to see rises. And because we're in Paris, I'll present some French data. On the left, you have the cases of recent syphilis. On the right, the cases of gonorrhea. And you see again in homosexually active men, this line here and here, you see from about the year 2000, the rates just have taken off. We saw that in Australia, you've seen that in the United States, and we've seen it in other countries in Europe as well. So we do have an epidemic of STIs now, in the era of HIV and in the era of controlled HIV or largely controlled HIV. If we go back to Sydney in my home country, you can see here that this is the incidence per 100 person years for HIV negative individuals to get syphilis and HIV positive. And this is another theme, that if you're looking at homosexually active men having sex with men, that the rates of the STIs in HIV positive individuals have historically been higher than in HIV negative individuals. And after adjusting for age in this cohort, Jeff Ginn and his colleagues found a hazard ratio of 9.2 if you're HIV positive. And this has been found in many studies around the world. Being HIV positive is a risk factor for other STIs, and that shouldn't be so surprising for a variety of reasons. Go back to the United Kingdom again, back to England. We can look here at new diagnoses of STIs from 1996 to 2015. We can see HIV infection, early syphilis, gonorrhea in the green, and chlamydia in the lilac. We see here the time frames of antiretroviral therapy becoming available in '96, PEP becoming available, the Swiss statement 2008, treatment as prevention really taking off in the UK, and then the proud results for PrEP. And you can see that the rise in STIs has really predated treatment as prevention and has certainly predated PrEP. PrEP may have been the cherry on top of the cake when it comes to increasing STI rates, but we've certainly had rising STI rates for many years. Once again, it's around the year 2000 we start to see these rates taking off. Turning now to the United States, 2015, the CDC put out this fact sheet. Sorry, 2016, they put out a fact sheet regarding 2015. The second year in a row that there's been an increase in all three of the major STIs, chlamydia, gonorrhea, and syphilis. 1.5 million cases of chlamydia, 400,000 gonorrhea, 24,000 syphilis, increasing, in their words, in their italics, at an alarming rate among MSM. I'm not quite sure I like that language, but I will agree with them that it is certainly increasing. And we've been seeing that once again before the PrEP era. This is my home state of Queensland. It's a fairly large state. It's about 3 times the size of France, twice the size of Texas if you're from the USA. And we have our QPrEP study, which is rolling out PrEP for people at risk in Queensland, predominantly MSM. We now have over 1,800 individuals in the study on PrEP at 22 sites across the whole state. Our STI rate at entry was 12.4%. At 3 months, 12% again. 6 months, 13%. We're not up to 12-month data yet. There are many other data like this. We've seen data from PROUD, we've seen data from EPIGAE of the very, very high rates at baseline, perhaps 30%, and maintaining that along the trajectory of those studies with levels of perhaps 25% at each check-in time. Why is all this happening? Well, this is more data from Australia, Gay Community Periodic Survey and other data over a longitudinal period, 1997 to 2016, showing the rates of homosexually active men using condoms all the time, not all the time, and those having no anal intercourse at all. And you can see that the number of men reporting that they're having more unprotected anal sex is certainly increasing. And the number of men who say they never have anal sex at all is decreasing. And this is certainly one of the reasons that we're seeing the increase in STIs. When the AIDS crisis broke out, of course, affected communities responded in a variety of ways. They decreased the number of sexual partners, they decreased the amount of anal sex they were having, they increased condom usage, and there was perhaps some sero-sorting going on where homosexually active men who are HIV negative sought out other neg guys and the positive guys sought out the pos guys. Now, in the era of highly active antiretroviral therapy and increasingly of PrEP, some of these differences are starting to fall away, and we're seeing the condom usage really declining. That's not to say that men are not using condoms at all, but that the rates do seem to be declining, and with that we're seeing a rise in STIs. One thing I do want to point out is to beware of vulnerable groups. We're doing a great job with HIV in many parts of the world, and we're seeing rates of HIV starting to drop, of course, in places like San Francisco, probably New York, Seattle, and in Australia as well. But this looks at Indigenous Australians, our first peoples in Australia, so Aboriginal and Torres Strait Islander people, and we had almost eradicated syphilis in 2008. And then we actually wrote an article, my colleagues and I, in the Medical Journal of Australia, saying we should be able to eradicate syphilis from this population. Of course, immediately we published that article, it went out of control. So I'm blaming myself and my colleagues for this rise in syphilis. It's not wise to tempt the gods, I think. And what we've seen then is an explosion of syphilis and more recently an outbreak of HIV in that very vulnerable, marginalised group on the back of the syphilis epidemic. And that's continuing at the moment, and we're having a really difficult time trying to control that. Canada, of course, saw the same thing in their Aboriginal populations. So the vulnerable groups are vulnerable for a reason, and they're vulnerable to STIs and HIV. So I think we've got to be very careful in these smaller groups that we don't lose them in the bigger picture, which may be getting better or worse depending where you are. I do want to end, though, on a good news story. Australia was one of the first countries to roll out the human papillomavirus vaccine for all teenage girls, so girls aged 12 or 13, and it's now been extended to all teenage boys of the same age, so all school-aged young people in Australia are given the human papillomavirus vaccine. This started for women in 2007. You see here in blue those under 21 who were the ones initially getting the vaccine. There was less coverage in this age group, and the over 30 we really had no coverage at that time. And you can see if you've got a good vaccine against an STI, and you're able to roll it out at the population level, this is the effect you get. A really phenomenal drop of 96% in genital warts in Australia. As a sexual health doctor, I used to spend half my time freezing warts off young people. I don't have to do that anymore, and I'm going to have to look for another job, I think, because it's freed up a lot of time. But this shows what is possible. The previous slide shows what's going wrong. Vulnerable groups, and in some places, gay men, very high rates of STIs. And this shows what's going right if you've got the right tools and you can roll them out. So I'll just end there and give my thanks to Jean-Michel Molyneux for helping with this presentation, and Professor Basil Donovan from Sydney, and also my QPrep team up in Cairns who helped with the data. So thanks very much.
Thank you, Darin. Very good presentation. So now the second speaker will be Scott Mcclelland. He's a professor of medicine, epidemiology, and global health at the University of Washington. His research focuses on prevention and treatment of HIV and STI in women. He's also conducted research in Kenya since '88. And currently, he leads several major NIH support studies in Mombasa and Nairobi. And he published work has advanced our understanding of the relation between genital tract infection and susceptibility of HIV infection. And he's going to talk about STI and susceptibility of HIV infection.
Thank you. Good. I was dreading if that didn't happen, having watched a lot of people struggle with it at this conference. So I'd like to start by thanking the conference organizers for the opportunity to make this presentation. I have research funding for HPV research from Hologic Corporation, Becton Dickinson, but no other conflicts of interest related to this talk. And by way of a very brief outline, I'll first summarize essentially the first 30 years of research into STIs and susceptibility to HIV, then shift to a focus on emphasizing conditions with the greatest potential impact on susceptibility at a population level, and finally highlight opportunities and challenges in future research in STI and HIV. So by the end of the first decade of the HIV epidemic, there was abundant epidemiological evidence that STIs might increase susceptibility to HIV. And as Mike Cohen has pointed out, this led to a series of quite high-profile clinical trials that I think will be well known to most members of this audience, of STI interventions to try to reduce HIV risk. And in the interest of time, I won't go into these in detail. But the long and short of all of this work is that only one of these 9 trials actually showed an impact on HIV acquisition. And this led to, in addition to post-traumatic stress disorder for a lot of investigators, a lot of questioning about what had gone wrong. One question was, is the underlying hypothesis wrong? And I think that while it's important to be circumspect and consider this possibility, that there are certainly a lot of other reasons that these trials may have failed to show an impact on HIV. Those include interventions that were simply not potent enough, effective control conditions in the trial, reducing HIV incidence in control arms, inadequate power in a number of the studies, behavior change in trial participants, and in some cases, interventions that may have been more effective at early stages of HIV epidemics rather than in more generalized epidemics. The other point that I would make is that with the exception of the herpes trials, most of these studies did not focus on the genital tract infections that really have the highest population level impacts on HIV. And to highlight this point, I'll use this figure from a paper by Lynette Massese, which illustrated the population attributable risks for HIV over a 20-year period from 93 to 2012 for a variety of different STIs. And the main points that I would like to make here are that basically two main conditions, genital herpes, and here I've combined prevalent and incident herpes too, and vaginal dysbiosis, and here I have combined both BV and intermediate vaginal microbiota by gram stain, account for much higher population attributable fractions of HIV than any of the other STIs or genital conditions shown on this table. These data are very similar to data from a population of general population women in Uganda and Zimbabwe, published by Janneke van der Weigert. So in both the high-risk population of sex workers and in the general population, these really stand out as high population attributable risk infections. I also want to touch on human papillomavirus infection, and data really have emerged primarily in the last 8 years or so that HPV is associated with increased risk for HIV acquisition. And because of its high prevalence and high incidence, it also contributes substantially to HIV on a population level. So to summarize the points in this first part of the talk, there are really three genital conditions that contribute substantially to population attributable risk for HIV: herpes, vaginal dysbiosis, and human papillomavirus infection. So I want to shift now to the question of how we would move forward in strengthening our understanding of causal linkages or ruling out causal linkages between these STIs and HIV. And I think there are two main pathways of inquiry. One is through demonstration of the mechanisms in the laboratory or in animal studies, and the other is by providing experimental evidence. And here I refer specifically to human clinical trials. In terms of understanding mechanisms, I think it's important to think in terms of a continuum from possible mechanisms, which we can essentially cobble together as hypotheses based on biological plausibility, to the highest levels of laboratory or animal study proof that we can gain short of experimental studies in humans. And I think the field of herpes and HIV has really moved by far the furthest along this pathway. Here I highlight data from a study by Zhu and colleagues, which was done using data and samples from the herpes suppression trials. And what these investigators found was that at the sites of HSV lesions, there were large numbers of CD4 cells present. These cells bore CCR5 and CXCR4 receptors. They were closely associated with dendritic cells and persisted for at least 20 weeks following healing of lesions, and that was true with or without acyclovir treatment. And finally, in ex vivo studies, biopsies from herpes lesion sites supported higher levels of HIV replication than biopsies from control sites. So a remarkable level of laboratory evidence that herpes may increase HIV susceptibility. Looking at vaginal dysbiosis and HIV, there's been a lot of excitement about this topic recently. I'll highlight just one recent paper published by Gossman and colleagues from Doug Kwan's lab. And in this study, working with data and samples from the FRESH cohort, so adolescent South African women at high risk for HIV, they first characterized the vaginal microbiota using a combination of broad-range PCR and deep sequencing. I'll focus here just on two main groups from the top sort of segment of this slide. Community type 1, which is women with a Lactobacillus crispatus dominant vaginal microbiota, and CT4, which was the most diverse type of microbiota. And if you go then to the lower left and then the lower right-hand side of this slide, what we see is that the women with the most diverse microbiota had the highest incidences of HIV infection and also had significantly higher numbers of activated CD4 cells identified on cervical cytobrushes. So certainly an intriguing argument that bacterial vaginosis or vaginal dysbiosis may increase susceptibility to HIV in women. With respect to HPV and HIV, this field, from what I can tell, is at a slightly earlier stage in terms of the laboratory evidence. But here we have data from a nice paper by Tobian and colleagues. On the left, skin from a penile biopsy of an HPV negative male. On the right, a male infected and then cleared HPV. And I think even in this large room, you can probably see the red staining dendritic cells, which are much more prominent in the man with cleared HPV. So finally, I'll shift to the question of how we might approach gaining experimental evidence about STIs as a risk factor for HIV. And obviously, our strongest evidence would come from randomized trials, but there are important barriers to conducting these in an era of effective HIV prevention. There will be low incidence in clinical trials where all participants are receiving interventions like PrEP. This raises a question I've heard discussed a number of times, which is it necessary to provide PrEP to all participants as a part of a trial, or where PrEP is broadly available, could trials simply counsel and refer? What if adherence to PrEP is related to adherence to new HIV prevention interventions? Is it ethical to randomize with all of the interventions that we have available? Are our current interventions even adequate? And finally, of course, randomized trials are quite costly, all the more so given the size that trials would need to be in the presence of PrEP or treatment as prevention to partners. One way around some of the ethical considerations with an intervention that should be rolled out more broadly is to use a step wedge cluster randomized design where all participants ultimately receive the intervention, but the sequence of the clusters receiving the intervention is randomized. And this is a design with many of the same strengths and limitations as a traditional randomized trial, and I won't go through those again, but adds, being a cluster randomized design, the difficulty of variability between clusters, logistical complexity, and bias due to changing HIV incidence over time. Despite that, I think that it's exciting to consider how this could be used in the setting of something like a proven intervention for HPV acquisition, so HPV vaccination, and in the course of scale-up to examine experimentally whether that also can reduce HIV risk. Finally, a number of people in papers that have examined HPV as a risk factor for HIV acquisition have called for pre-post type studies following HIV incidence before and after rollout of HPV vaccination. And I think that this is an important thing to do, but would still caution that this is back to an observational study design and better suited to generating rather than proving our hypotheses. So I'll close with three main points that I'd like you to take away from this part of this symposium. First, that genital infections that contribute highly to the population attributable fraction of HIV may be our best targets for reducing HIV susceptibility. Second, that it's important to avoid moving to our large and costly trials without understanding the impact of our interventions on the mechanistic intermediates leading to increased HIV susceptibility. And finally, that trials to prove causal associations will require thoughtful design to address new challenges in an era of effective combination HIV prevention. I have far too many individuals to thank one by one for my thinking on this over the past 20 years or so. Many institutions have also contributed to my work and my thinking on this. I do want to specifically call out Judy Wasserheit, who helped me in thinking about how to cover this much data in about a 10-minute talk. So thank you.
Thank you a lot, Scott. So it's my pleasure to introduce Connie Salem. She's a professor of global health and medicine, adjunct professor of epidemiology, and co-director of the International Clinical Research Center in the Department of Global Health at the University of Washington, and also an infectious disease epidemiologist with focus on HIV prevention that includes efficacy trials of herpes suppression and PrEP.
Thank you. So in addition to the usual thank yous for being asked to give this talk, I want to thank the conference organizers for including this symposium. Go to too many HIV meetings where STIs really are the poor cousins and not covered very well. And then secondly, I want to thank all of you who are here and show interest, including some fellow warriors on this path who also had PTSD when some of our interventions didn't work. But I'm going to try in my 10 minutes to really convince you that I think there are still, there's certainly importance. I think Darin's topic conveyed that. We can't neglect STIs, and I think there are opportunities to come up with new interventions in this new era. So I'm going to actually really skip the first bullet because I think Darin did it so beautifully, and I'm going to really focus on the last three topics that I really think part of the innovation needs to be how we actually reach people and deliver services for STIs, and we need innovation. I also think we need resources, and thought that the Lancet, I think HIV or ID, sorry, issue that came out last week really calls us to action to not neglect STIs and not to underfund it. And then I'm going to end with several examples of successful delivery models and innovations that I think should prompt us to think more deeply about this. So as promised, I'll skip through the epi slides and then just say, and then came PrEP. Because I think that's really, there's been a lot of discussion, not just at this meeting, but at many meetings about whether PrEP is responsible for these increases in STIs and whether or not STIs will modulate the effect of efficacy of PrEP. And for the latter point, you know, first of all, I think the first point, I feel pretty convinced from the epi data that really it's not due to PrEP. PrEP came along after the STI curve started going up. For the second question, does PrEP work in people who have STIs? The data really consistently, I think, say no. You could always argue we want more data, but these are the data we have. We had high syphilis incidence in the trial of PrEP among MSM. There's no efficacy difference in men with or without syphilis. Although we had a lower prevalence and incidence of STIs in our Partners PrEP study, we also found no difference in PrEP efficacy among those with or without STIs. There's been a lot of discussion, including earlier in this conference, about the influence of bacterial vaginosis, or vaginal dysbiosis, as some call it, on efficacy. And it does, in our study, in Partners PrEP study, where we had a pretty high prevalence of bacterial vaginosis, we found no difference in efficacy among women who did or did not have PrEP. So it's a different set of issues with topical delivery, where I think the data do suggest that vaginal dysbiosis may alter the metabolism of topically delivered tenofovir. But we're talking about oral PrEP because that's what we have now, and the data don't support diminished efficacy. And even more importantly, I think when we started rolling out PrEP in the first trials of open label PrEP, where people knew they were presenting because they perceived themselves to be at risk, and not surprisingly, the prevalence of STIs was higher at baseline, and also incidence was higher than in the earlier trials. And we found that the effectiveness was even higher than what was observed in the randomized controlled trials, both in the UK study, PROUD, and the MSM PrEP demo study in the US. And so I think we should really feel comfortable that we have an effective intervention that retains its efficacy in the presence of STIs. And these are just some of the data. You may have seen this earlier in Sheena McCormick's talk, but the prevalence and incidence is concerning, but it's not due to PrEP. What this tells me is that we're reaching the right people with PrEP, and we should celebrate we actually have a new intervention to offer them. I think in the US, similar data were found in a fairly large cohort through the Kaiser Permanente system, where there are now well over 1,000 men, and they have not seen any HIV incident HIV cases in the context of very high rates of bacterial STIs. So to summarize that part of the talk, in the context of this global STI epidemic and growing use of PrEP and earlier ART treatment, STIs are even more important to diagnose and treat. That bacterial STIs and bacterial vaginosis do not reduce the efficacy of oral PrEP. The STD field, in my humble opinion, needs reinvigoration and continued funding, as articulated, I think, in the Lancet Commission on STDs this month. And that it's our responsibility to take advantage of the opportunities we have as people are coming into care for PrEP and treatment to screen and treat STIs in populations with high incidence. And that means, I think Darin said it very well, you won't find it if you don't look. We should be looking and using appropriate testing. In many settings, that means we need to do better than syndromic management, and that should be a real priority. So another question I wanted to address is, can PrEP programs actually help by reducing STIs? And I think absolutely they should be able to. Typically, people are being given 3-month supplies. STI testing is done, depending on the setting and the population, quarterly in some cases, every 6 months in others. So we should be looking for STIs and treating them. I'll touch on the issue of, can we also do more than just diagnose and treat it? Can we treat it earlier through post-exposure prophylaxis, which was some really interesting work presented by Jean-Michel Molina at Croix this year. And then I think, thinking more broadly, can we not just rely on people coming to us, but can we do better and move out of the clinics and get STI testing to people in the community in the way that we have the potential to do with HIV self-testing kits? And we'll touch on some work that Patrick Sullivan and the Emory group are doing. So hopefully it's clear. I'm trying to make a case for a call to action for innovation in STIs. A lot of people, I think those of us who did start, as Mike said earlier, in the STI field, need to work with our colleagues who are still predominantly working STI clinics and change the model from disease models to sexual health clinics that are user-friendly. Think about whether we can do better to either prophylax after exposure or even before exposure. And perhaps it's a time to come back to herpes, as Scott Mcclelland talked about, and think about, could you pair valacyclovir with PrEP to reduce HSV2 incidence and or shedding in people who already have herpes. So I just want to end with some examples which I think are exciting and show there is room in this space to do things differently. For those who heard Sheena McCormick, either at Croy or at this meeting, talk about the Dean Street Clinic, I think this is great. They've taken the model of an STI clinic and reconfigured it to be really a sexual health clinic. It's attractive to high-risk groups. It's in a busy part of downtown London where people are going anywhere for shopping or other reasons or work. They encourage more frequent testing. It's been shown to reduce costs. And I think that part of their success is that they did pick a good location and they branded it well. They've also shown that self-service is feasible and well received, that they use computer technology for people coming to the clinic to take a history rather than have to do face-to-face interviews, as well as to obtain swabs. They used a lean design to cut out unnecessary steps, errors, and found that it achieves better outcomes. And so they removed many of the steps, some of which take time, some of which lose samples, some of which involve transcription errors, and reduced the cost because this approach also reduces time in the clinic and staffing. And very importantly, they showed that they could dramatically reduce the results. And not everyone can do this with a big PCR machine in a clinic, but I think it shows it's feasible. And for very large urban areas like London, maybe this is a good investment. To go from 183 hours to 4 hours for results is really remarkable. You're going to get people to get treatment. More people will be treated, and they'll be treated sooner, which will reduce infectiousness. I think New York also should be called out for their innovation in terms of going to a status-neutral approach where they're changing their STI clinics into sexual health clinics, where they're offering expanded services, including mental health, substance use counseling and referrals, PEP, as well as PrEP, rapid ART initiation, and importantly, I learned when I visited in June that they trained the staff in consumer services approaches, like how do you treat people nicely and attend to their needs, so it's really a user-centered approach to care delivery. So they've taken the approach that basically prevention and treatment are part of the same continuum, and that these clinics should be able to deliver both prevention and treatment, and that this is the best way that you're going to really get people in the door who don't feel like they're going in one door if you're negative and another door if you're HIV positive. And lastly, I think innovation is happening in other parts of the world, and we should applaud people such as some of our colleagues in Johannesburg at WITS RHI, where they're moving to a more integrated sexual health program targeting youth, where the prevalence of HIV, but also bacterial STIs is very high, and they're seeing over 1,000 young people per month. So I think all these examples show it can be done. It takes commitment, motivation, and resources, but it yields results. So clinic innovations are needed, but we also need to reach people where they are. And people, honestly, would prefer not to wait in a clinic many times. And when we think about PrEP, really in a HIV-negative population, you probably can deliver it outside of clinics. There were several presentations at Croy this year, including one from a pharmacy group in Seattle that showed you can deliver PrEP well and safely with high acceptance and reach men, many of whom did not have a primary care provider. And all this was done under the guidance of a physician medical director, and they found very high demand, retention, and acceptability, and many of them were eventually connected to a primary care provider. Some, about 10%, also were diagnosed with STIs and had those treated. So let's think broadly about how to do this. And part of that broad thinking has to be people are using the internet for everything else, ordering every kind of consumer item, including birth control and PrEP. Some innovative people in the San Francisco area developed a program called NERCS. They started with birth control delivery. Again, there's physician backup and screening and testing involved. but it makes it very easy for people to get actually either birth control pills or PrEP delivered to their door. Lastly, I want to call out Patrick Sullivan and his group, because as we were getting some experience in some parts of the U.S. with HIV self-testing, they took it the next step and did a mail-out kit with basically all the swabs and materials needed to do self-testing for STIs. It's a pilot, but they are working with Amazon, and I think if the pilot works, this is something that, again, why can't you get STI screening on Amazon if you can get everything else? And what it looks like is that they're doing this as part of PrEP initiation and follow-up, and they get mailed in a very discreet Amazon package, all the STI testing, so that they then return to the lab receives the kits, they link this in this research project with a behavioral survey, send it to the provider, and then the provider can treat people who have STIs. So those are innovations in delivery. Let's just end by talking about innovations in interventions. And I want to call out the IPRGAY trial for thinking about doing a nested study of post-exposure STI prophylaxis with doxycycline. And I think most people know about the design, overall design of the IPRGAY study, but they nested into this among men who had no contraindications to doxycycline, which I think is most people. On-demand PrEP with doxycycline 24 hours after sex, up to 72 hours after sex, or no doxycycline. And as Jean-Michel presented at CROI, they found a significant reduction, highly significant reduction, in time to first bacterial STI. And when you break it down by different STIs, that significant result was time to first chlamydia, time to first syphilis diagnosis. They did not see a difference in, and maybe we could anticipate this, in reduction in gonorrhea incidence, probably because much Gonococcus is resistant to doxy. So just to conclude, I think this is a time where we should really take the opportunity to think hard about how to be innovative and how we deliver sexual health services and STI diagnosis and treatment, better use of rapid testing models, sexual health clinics that are client-centered and efficient, maybe self-assessment apps, examples being HealthGrinder and SexPro, that are in various stages of development. And then let's think about how to reach people where they want to be reached, which is not typically in a STI clinic, and find access points either through pharmacy or online that are closer to patients. And then lastly, for those who are looking for new research ideas, let's think about post-exposure prophylaxis. Would the doxycycline PEP approach in IPRGAY work with daily PrEP? We don't know. Could be evaluated. With pre-exposure prophylaxis, since we have very little to offer at this time without a herpes vaccine, and we know, at least in our Partners PrEP study, we had a very modest reduction in herpes with tenofovir-based PrEP. What about adding valacyclovir, which is very well tolerated, now generic, to Truvada? This would be a good randomized controlled trial. So I just want to thank the many people who provided slides and ideas and inspiration for me to think again about STIs, and hope that we collectively as a field can move STIs into the 21st century. Thank you.
Thank you, Connie. C'est un plaisir de faire l'introduction de Cécile Beber. She is PhD medical doctor and professor of clinical microbiology in the Department of Bacteriology at the Bordeaux University Hospital and at the University of Bordeaux, France, where she served as a director, and also she coordinates the French National Reference Center for Bacterial STIs.
Thank you, Adele. Good morning, good afternoon, everyone. I'm sorry. First, I would like to thank the organizer, especially Jean-Michel Molina, for having invited me to give this talk on antibiotic resistance in bacterial STI. My disclosure. So, as we have seen in the first presentation, the WHO in 2012 reported 130 million new cases of Chlamydia Trachomatis, 17 million new cases of gonorrhea, about 6 million new cases of syphilis. There is also an emerging STI pathogen, Mycoplasma genitalium, which is excessively prevalent but was not estimated by the WHO report in 2012. So there is a concern with the emergence of antimicrobial resistance, AMR, in this bacterial STI, which can reduce the treatment options and the STI control. So I'm focusing today on these 4 bacteria. First, Chlamydia trachomatis. This is an obligate intracellular bacterium, and the current recommended treatment for uncomplicated urogenital infections is first-line azithromycin 1 gram single dose or doxycycline for 7 days. There are some alternative regimens, either tetracycline or erythromycin or fluoroquinolone. And for rectal infections, doxycycline is recommended for 7 days, while for LGV, doxycycline is recommended for 21 days. For Chlamydia trachomatis, the acquired AMR in patients is very rare. For macrolides, resistance has been described only for 4 clinical strains, and this resistance is linked to mutation in the macrolide ribosomal target, which is represented here on the, excuse me, I don't find the, oh, oops, the, on this scheme with the 23S RNA here, ribosomal target. And this mutation have been selected also in vitro resistant mutant after exposure to macrolides. Tetracycline. To date, no resistance among clinical strains of Chlamydia trachomatis. However, resistance has been described in a porcine species, Chlamydia suis, via an efflux TETC pump gene, and this gene is located in a genomic island. And in vitro, the horizontal gene transfer of this TETC gene has been demonstrated between Chlamydia suis here and an in vitro generated Chlamydia trachomatis mutant resistant to Oflo and rifampin. Fluoroquinolones. No resistance described among Chlamydia trachomatis clinical strains, but again, in vitro resistant mutants were selected after exposition to sub-inhibitory concentration of quinolone, and this resistance was linked to mutations in the fluoroquinolone enzyme targets, that is to say DNA gyrase, and this mutation led to high increase in MICs, as you can see on this table. Now, Gonococcus. So it's not the same thing. For Gonococcus has become resistant to virtually all antibiotics since sulfonamide were used in the 30s. In 2010, the first 2 strains of Gonococcus resistant to ceftriaxone, the extended spectrum cephalosporin, were described in Japan and in France. And a year ago, the first clinical failure to the dual antimicrobial therapy, ceftriaxone and azithromycin, was described in UK. So, Gonococcus has evolved into the superbug status and might become untreatable in some special circumstances. According to this superbug status, in 2010 and in 2012, the empirical first-line treatment recommended for uncomplicated gonorrhea has been changed and is now a dual antimicrobial therapy with ceftriaxone 250 to 500 milligram plus azithromycin 1 to 2 gram. On this slide, from the very interesting publication from Rui et al. Published 2 weeks ago in PLOS Medicine, you can see the percentage of isolates of Gonococcus with decreased susceptibility or resistance to extended spectrum cephalosporin, ESC, either cefixime and/or ceftriaxone, according to the 2014 WHO-GASP data. And you can see that this percentage ranges from less than 0.1% in blue, from 6 to 30% in orange, and for instance, in France, this percentage ranges from 0.25% to 5%. When we look at the main mechanisms of resistance to ESC in Gonococcus, there are 2 major mechanisms. First, the alteration of PBP2, the lethal target for ESC, but also the hyperexpression of the MTR-CDE efflux pump represented here. What about azithromycin resistance? This resistance ranges from 2 to 8% according to the different countries, and the high level to azithromycin is mainly caused by mutation in the macrolide targets. Fluoroquinolone resistance, 30 to 50% according to the geographical area, and the resistance is linked to mutations in the quinolone enzyme target, DNA gyrase. Tetracycline resistance lands more than 50%, and the high-level resistance is mainly caused by the TETM gene, which is carried on the mobile element. What about syphilis? Since more than 50 decades, the first-line treatment for syphilis is benzathine penicillin G for all stages of syphilis, and to date, no clinical AMR has been described. Alternative regimens include doxycycline of ceftriaxone or azithromycin. No clinical AMR to tetracycline has been confirmed. However, there is a concern for macrolide and especially azithromycin. And there is, in some geographical areas, there is a high prevalence of azithromycin resistance since the first cases was described in 1977. The mechanism is linked to mutations in the 23S rRNA ribosomal target. And I can show you some clinical resistant rates ranging from 60% in UK to 100% in China. Now, what about Mycoplasma genitalium? Tetracycline, there is a low eradication rate for M. genitalium clinically, but no acquired resistance described to date. So, according to the recent specific European guideline released by the EU STI Europe a year ago, the recommended treatment for uncomplicated M. genitalium infection is azithromycin for 5 days. However, there is a huge concern of clinical acquired resistance to macrolide for this microorganism. This resistance is caused by mutation in the macrolide target, the 23S rRNA, and this is most likely caused by azithromycin 1 gram single dose due to the widespread use of this macrolide in clinical STI setting. On this map, you can show the prevalence of macrolide resistance in Mycoplasma genitalium, which ranges from less than 10% to more than 60% according to the geographical area. And you should note that there are a lot of small prevalence studies with a small number of patients. So in case of complicated Mycoplasma genitalium infections or macrolide-resistant M. genitalium infection, the recommended treatment is moxifloxacin, the fluoroquinolone, for 7 to 10 days. However, there is a concern linked to the emergence of clinical acquired resistance to moxifloxacin by mutation in the quinolone target, this time in the topoisomerase 4. This resistance has been demonstrated both in vitro and clinically with clinical failure in patients. There are few studies to date, but the prevalence rates already described range from 5% in UK to 50% in Japan. So in conclusion, should we fear antimicrobial resistance for bacterial STIs? Clearly yes, but there are distinct situations. Neisseria gonorrhea and M. genitalium are evolving into so-called superbug and might be untreatable in some special circumstances. By contrast, Chlamydia trachomatis remains susceptible to many antimicrobials. And syphilis remains susceptible to the first-line drug treatment, but there is some concern with azithromycin in some geographical area. And for more information, I would suggest the reading of this very interesting publication from the Lancet Infectious Disease Commission, which has been released in the Lancet Infectious Disease a week ago. And to finish, I would like to thank my colleagues from the French National Reference Center for Bacterial STI, and first Béatrice Berceau. She prepared with me this presentation, and she's the head of the Associate Lab on Gonorrhea in France. Also Nicolas Dupin, who is heading the Associate Lab on Syphilis, and colleagues from my lab with a special expertise on Chlamydia Trachomatis and urogenital Mycoplasma, Olivia Pechamp, Sabine Pereire, and Bertie de Barberac. Thank you for your attention.
Let me thank all the speakers and point out that we have some minutes for questions and comments. So I would welcome you all to stay and ask questions and comments. I'll start out by making a comment and then trying to stimulate some sort of really big debate by provoking some sort of fight and evoking new enemies in the audience. So the first issue is about PrEP. So pre-exposure prophylaxis, I think right now the only drug approved is the combination of TDF-FTC or TDF, the tenofovir-based approach. And I think it is very clear, as Connie said, that with that agent, it is robust. In fact, sexually transmitted diseases have been observed, and HIV acquisition has not been observed in that setting. So the drug appears very robust when the barrier might be lowered to a transmission event. What I worry about is do not believe that we know that for the next generation of pre-exposure prophylaxis agents that they will be just as robust. Because the biology of each of the agents we're testing is different. They include injectable agents and antibodies, and I do not think we should make any assumptions. So we have to have our guard up. That's my first point. Then the question, Connie agrees, I think.
That was not a fightable question.
And now I will ask the fightable. I will start the stimulative fightable questions. I think what I'm a little concerned about is we've kind of, in the discussion about, there's almost a defensiveness in the PrEP investigators that we didn't cause the STD epidemic. You know, we've heard 3 speakers all say, this isn't our fault, it was already occurring. And I'll accept that. That's not the issue. But I think it did start around the time that we made HIV look less ominous. So when you look at the slides that are available, and Darin showed it beautifully, in 1989 we got AZT, 1990. By 1996 we had triple drug therapy, but it was 16 pills a day. It was around 2000, 2001 when we started moving towards much simpler regimens. 2006 was 1 pill a day. I think that there's an evolutionary biological thing going on where a terrible disease, and I'm not endorsing what happened, but a terrible disease helped change behavior. STDs were kind of lying kind of low, and then as treatment became better and better, way before PrEP, behavior change that might have been inspired was offset, and leading us to where we are now with a really big problem with STDs. So I don't quite know where we go from here. This is the question. None of the speakers told us what to do next. Connie kind of did, but I'm not sure that's sufficient, okay? Because the epidemics are too big. So where are we really going to go next in order to deal with this? And how do we see it as an evolutionary event, and what's going to happen next? Scott and Connie and Darin, you're all welcome to solve the problem.
I'll take the bait. I'll start off. Look, I think there's a couple of options ahead of us in the future. One is that we just continue having very high rates of STIs, and that's certainly what we've been seeing the last few years. Despite whatever we've tried to do, it hasn't worked. So if we keep doing what we're doing now, we're going to keep getting what we've always had, and we're going to have high levels. I kind of believe that behaviour change is not likely here because these things are not killing anyone by and large. They're not creating terror, so people aren't going to change their behaviours very much. So that then leads us to more biological interventions, and I think Ipagay has pointed the way with on-demand doxycycline. As Connie said, we need to know if daily doxycycline would do any better, and perhaps it would do a bit better with gonorrhea. We don't know, because of the high turnover of gonorrhea. By the time some of the men took doxycycline, it may already have been established, and then it wasn't preventive, it was treatment, and it wasn't good enough. But I kind of think my last slide I showed of the HPV prevalence, or the genital wart prevalence, dropping dramatically, shows what's needed. We need better tools.
It shows that vaccines are really great tools compared to pills. Well, let me ask the questions from the audience. Microphone 4, four questions lined up.
Hi, it's Ben Ryan with Pause Magazine in the United States. I want to thank you, Dr. Cohen, for your remark about a certain amount of bias that I have certainly observed in researchers behind PrEP of sort of gearing up to say it's not our fault. I sometimes feel that that bias can cause these great intellectuals to take off their intellectual hat and just look at PrEP in a binary sense. It does or does not influence rising STI rates or change of condom use rates. I would much prefer they look at it as a multifaceted thing in which PrEP is being introduced to behavior change and affecting it along with many other variables. Beyond that statement, I want to ask the last presenter, Dr. Bebiar, I think is how you pronounce your last name. You described, the possibility of, in special cases, having untreatable gonorrhea. Can you just go into a bit more detail for like a layman's sense of what that would mean? Are these going to be little pockets, or are they going to perhaps transmit widely and cause a lot of chaos?
You asked me about untreatable gonorrhea, that's it?
He's asking for like a movie. He's saying, like, tell me what a movie looks like with untreatable gonorrhea.
Is it a boring
So
movie? It's
what
like
is
a
the
couple
species?
cases in
What is
Kansas.
this?
It is a nightmare. It could be a nightmare, but
People ask me this a lot, so,
But there are some development of new antimicrobial who can be effective on this untreatable gonorrhea, especially with fluoroketolide, but also some anti-topoisomerase inhibitors, and also some chloromethylene antimicrobials. So there are some new drugs in development which can help to treat this strains resistant to extended spectrum cephalosporin.
Yeah, I also think, realize in Malawi, for example, the only drug used to treat gonorrhea for 30 years is gentamicin. So the aminoglycoside gentamicin, which people don't like using because of some toxicity, once a day, one shot of gentamicin at 240 milligrams has been effective for a very long period of time. And as was just stated, there's a whole bunch of drugs in development, and I think the vaccine field is getting re-stimulated in gonorrhea vaccine development. Let me just note that our colleagues in New Zealand looked at gonorrhea incidence in the face of a meningococcal vaccine that was widely used. And they saw a pretty precipitous fall in gonococcal incidence that they ascribed to the meningococcal vaccine. Now that has stimulated then vaccine developers to say, wait, if there's a platform for a gonorrhea vaccine, let's get started. So I think that you'll see then movement towards a vaccine. As was already pointed out, the HPV vaccine made a huge difference. A gonorrhea vaccine would be a very interesting vaccine. Scott, did you want to say something?
I would like to make a point. I think we have to stimulate countries to have their own network to monitor gonococcus resistance, because not every country is the same. So this is sometimes hard to put STI in the agenda and the priority, but yes, we have to talk about public policies, and this is a major issue that we have to fight to be in place in countries.
Is Brazil monitoring gonorrhea resistance?
Yes, sir.
Let's go to Ben. Can we get next question, comment question. Thank you, Ben.
Good evening. I'm Dr. Guru Prasad from India. I have a question regarding, I have 2 patients who are well controlled with virologically and immunologically, but still herpes zoster repeatedly it is coming. Once they stop take for treatment for a course, again as soon as you stop it, again the recurrence of herpes zoster at the same place. I have 2 patients who have been for this since 1 year. Even after prophylaxis of 6 months, we gave Acivir, and even we tried this thing.
This is repeated chlamydia, is that what you said? Which infection?
Herpes, herpes zoster.
HSV, okay, Connie.
Yeah.
VZV, you talk.
It's unusual. So in the context of good, if I understand, good virologic and immunologic response to HIV, I mean, that might be a situation where you would want to try to culture it and see if you can see if there's acyclovir or valacyclovir resistance. You know, and if someone was, another possibility is even though they had a CD4 rebound, that if they really started treatment with a low nadir, that they don't have, that the immune control for specific pathogens like VZV, which they acquired as a child, may not be as robust as you think based on the CD4. So I think you need to rule out resistance to acyclovir and which would give you a surrogate for valacyclovir resistance. But also, if you don't find that, I think you're probably just going to have to, you may want to put them on persistent valacyclovir suppressive therapy.
Thank you.
Valacyclovir, like, you have any experience of giving for, what's the duration like if you think about that? Ideally prophylaxis, something like that, 6 months?
It's not something that I think there are any guidelines about, but we use valacyclovir suppressive therapy with pretty high, you can use it for fairly high doses, which you would need to for VZV, and it has very little toxicity, and as long as you've ruled out resistance, I think it would be one approach to consider.
Thank you.
Microphone 5.
Hi, good afternoon. Bob Bolin, Los Angeles LGBT Center. I think as long as we keep the linkage between increased testing for STIs together with PrEP, we'll be on the right path, at least, for addressing the increased STI rates at the same time as we're providing HIV prevention, so that folks are coming in a lot more frequently for STI testing. In our center, we require people to come in every 3 months for STI testing along with the HIV testing. I think the idea about becoming more creative and innovative about having, you know, like STD supermarkets like the Dean Center, where people can come in and, you know, get their HIV test, get their STD test, and get their PrEP prescriptions, will really go a long way. So I like what you were saying, Dr. Cohen, about going back to our roots. You know, I'm one of the warriors that started off at the beginning of the epidemic as well. And I think that the beginning of HIV was definitely an STD epidemic, and we ought to keep that framework going forward.
Yeah, thank you for that. Again, I think that these comments that were made are correct, that the biological solutions are probably required. Re-stimulate the vaccine field, which is really dormant. Syphilis vaccine, there's actually a meeting about syphilis vaccines at NIH on August 30th. Gonorrhea vaccine, we see industrial movement. HPV vaccine, the PAF thing is challenged now. That is it really true that HPV vaccines will have an effect on HIV? It's pretty interesting. And then antibiotics as co-treatments, that's a bigger stretch, but it's happening. And then the Dean Street Clinic is a structural intervention, essentially. It's create a supermarket. I've not heard it called, I'm sure they don't want to be called the supermarket. So create a robust setting. And then number 4.
UT Southwestern, USA. I just have a comment and a question. It's firstly really reassuring that really high-profile researchers understand that STIs and HIV are pretty much part of the same continuum. The CDC funding for HIV prevention is so vastly higher than STD prevention. It's sometimes, I don't understand why there are such silos of care for something that's part of the same disease spectrum. And the question is, with the rising rates of gonococcal resistance, is Cefepime monotherapy for expedited partner therapy, are those recommendations going to change, and should they change? And is there more data coming up on EPT for MSMs? Because right now there's no guidance on that.
Oh, these are really good questions. Now, this is about the U.S. policy, although we're not in the United States. Scott, are you familiar enough to take that question? Or Connie?
No, I'm not
Just
sure
talk.
if this is on. Is it on? I'm not aware that there is yet a change in the recommendation for EPT with Cefepime, and certainly Seattle, where I work, has been a leader in rolling that out. I do think there needs to be reconsideration of the use of cefepime monotherapy, in particular because cefepime, to a much greater extent than ceftriaxone, seems to promote the emergence of gonococcal resistance. So I think that that may be a problem. I want to circle back just very briefly to the question of what it would look like to have, sort of extensive resistant gonorrhea globally. And I think that while it's easy to fall back on the fact that there are indeed new promising drugs and some old drugs that may still work, I think that in countries with less robust healthcare systems, like the places that I do a lot of my work, this is unlikely to be caught early. Those new drugs may not be available as early. And I think that this will be a problem, as with many STIs, where the brunt of the complications are going to be borne by women. And these are going to relate to infertility and birth complications.
Cecile?
Yes, I fully agree with Scott. I don't think that cefepime would resolve the problem of resistance to ESC, because it's the same than ceftriaxone, and ceftriaxone is more active than cefepime. It's not the great solution.
So both of you are afraid that current guidelines, if we're concerned that ceftriaxone concentrations required to treat infection are rising, and that some bugs have actually been discovered that are pretty resistant, you're worried cefepime is just going to put more pressure, exactly the same kind of resistance requirements. It'll put even more pressure on this problem. That's what you're saying. Is that correct?
Yeah.
And then the partner issue that she raised is really important. It is incredible that in 2017 we have not effectively dealt with the best way to create situations where partners, whether HIV uninfected or infected partners, or STD infected or uninfected partners, where they're not dealt with effectively. It's just incredible, and it's a failure no matter how we look at it. Okay, next.
Eric Loya, U.S. National Trade Association for the Adult Industry. I have a quick question. So, do we have any data on how many tests are done in total and how the rate of total tests taken has increased in comparison to the total number of positive tests? Because my concern is that what we're looking at here could potentially be an incomplete data set. Because as we continue increasing testing, we'll naturally find more infections, and therefore our STI rates rise. So I just want to know what that ratio is.
Yeah. First of all, I think everyone agrees with you. I think every epidemiologist agrees that. They think that testing, the more we do testing, the more likely we are to increase the number of positives. And the testing has definitely increased as our guidelines have required testing every few months. I don't know, though, that anybody's characterized the number of tests that have been completed or done. Do you know, Darin?
Sheena McCormack, I think in a plenary yesterday, presented some data from Dean Street again, showing that the number, when they moved to their the new model at Dean Street, the number of tests for chlamydia and gonorrhea just rose dramatically. But they weren't finding any more chlamydia. Like the diagnosis rate went up with the testing rate. For gonorrhea, however, they found something quite different, that the testing rate went up and the diagnosis rate went down.
One thing, there's no way to be happy that the more tests still, for the most part, show more disease. In other words, it's still our problem. So while while we might conclude that the species isn't changing as dramatically as is apparent, it's still a big problem for the species. So. Richard Hayes, this will be a really special comment. Richard was one of the really fathers, or you may be a grandfather by now, the father of STD intervention, and wrote many articles on this issue. Wait 1 second, it's not on yet. Wait, okay, now.
Can you hear me? Yeah, I'm not a grandfather yet, but thanks for giving me the chance to comment. So as actually one of the leaders of the one randomized trial that did show unequivocal evidence of an effect of STD control on HIV spread, and I don't think we should forget that. I really hate people who get up and end up speaking for longer than the people on the stage, so I'll try and keep my remarks short, but I did have 3 or 4 comments.
We would let you have all the time you need.
Thank you. So the first is about the neglect. I'm trying to be controversial here because I think you wanted that. I've been ever more dismayed, actually, over the last few years by the neglect of STIs and their interaction with HIV at these international conferences. And I'd like to appeal to the organizing committee to make sure this doesn't happen in future conferences. It's great that we've had this session this afternoon, but even this session has really focused mainly on relationships with delivery of PrEP, which is important, but it's only a small part of this problem in my view. What we haven't talked enough at all about is the point made by Scott. He showed those really dramatic attributable fraction estimates for these highly prevalent infections and conditions in generalized epidemics in Africa. So we're talking about HSV2, for which prevalences are over 80% in many populations. So this is almost a universal infection. We're talking about bacterial vaginosis, which has also very high prevalences, often 40–50% in general populations in Africa. We're talking about HPV. We're talking about these highly prevalent conditions where there is very strong evidence that these conditions are dramatically increasing the spread of HIV. So where is the discussion of this at this conference and in other conferences to set the research agenda for control measures against these major infections? I'd like to see much more discussion of what tools we should be developing and how to evaluate them. For example, could we have some comment from the panel on what's being done right now on the development of HSV2 vaccines that could potentially be a game changer for HIV control? Thank you.
Thank you, Richard. Well, I mean, it's almost like when they indicated they were going to have this session, and then I realized they're having this room, I had this wave of fear there'd be one person in this room. And we would, and the one person would be the second speaker. There'd be the first speaker and the second speaker. So I'm very thrilled with this nidus of committed thinkers. I suspect, I mean, and the history of how these fields started out as separate, because we did not know at the time of HIV recognition as the pathogen, even before then, the people who got early on involved in understanding and dealing with HIV were not STI specialists. It was only years later that it became a sexually transmitted disease. In fact, there was a fight against the belief that HIV could be heterosexually transmitted until 84, let's call it 83, late 83. So the schism has not served the community public health. The question is, as you just put out, how does one reset the agenda so that HIV dollars are, I wouldn't call it shared, are commensurate, are coalesced with STD dollars? That's a challenge. That's the first point. The second issue is HSV2, which has been Connie, and you spent a lot of time thinking about this. I suspect that both of you would like to say more about HSV2 vaccine development. So, Richard, was that a rhetorical question or a real question? Okay, so Connie.
Well, I think we've unfortunately had failures with the first generation of recombinant DNA-based herpes vaccines, and that really, and a lot of resources went into it. And so I think what happens, I mean, I'm not sure how to be concise about this. I think there's, people got so discouraged that basically they've moved to the idea, from what I gather, of a therapeutic vaccine. And there is some encouraging results there. And given 80% prevalence in some populations, that might have an impact. But I think actually if it hasn't been done, to my knowledge it hasn't, it'd be really good to know how potent does it have to be to have a population level impact on transmission. The thing that encouraged me a little bit, I wasn't at this meeting, but I think it was a few months ago that WHO convened a group to think about a herpes vaccine and the product profile that would be desirable. And people I've talked to who went to it said some of them, like myself, had sort of gotten really discouraged about this whole question, and they said it actually was a reinvigoration, and I think hopefully that'll translate to some movement. But it's been challenging, and I think it partly loops back to some comments that Scott made, that I think we started down this path before, like with our herpes suppression trials, not really understanding the persistence of immune activation. So maybe we have to accept that we are in the foreseeable future not going to have perfect tools, but let's use ones we have while we try to keep pushing on vaccine development.
There's just one brief comment. This is not going to be a popular comment. Herpes viruses are extremely ubiquitous. They're extremely efficient, and they play a role for thousands of years. EBV virus, of course, is acquired by children, and there's some, a lot of evidence about how EBV interacts with our immune systems, et cetera, et cetera. HSV1 is what 98% of the species. So to believe that we're going to outwit an effectively transmitted virus, that is HSV2, that's a big lift for the species given the prevalence of other herpes viruses. So I think Mother Nature has kind of something going on here with herpes viruses. That's not to offend my colleagues. Okay, number 5. Your microphone's not on yet.
Jim Braun from New York City Physicians Research Network and Callan Lord Community Health Center. Now that most of our labs have shifted over to nucleic acid testing for diagnosis of gonorrhea and chlamydia, I'm wondering if there's any research and development going into better testing, because with what we have today in the clinic, we can't find LGV. It doesn't diagnose LGV. We used to get LGV testing done for our positive chlamydia test through the CDC, but they cut back on funding, and that's no longer available. So we have frequent incidents of triple site chlamydia infections, and we don't know whether it's LGV strains or not. Also with gonorrhea, we can't do cultures. We're getting positive tests back, and the only way we can diagnose a drug-resistant gonorrhea usually is through treatment failure. So I'm just wondering, is there any research and development that will help us avoid inappropriate or subtherapeutic treatment for these kinds of problems?
Those are great questions. Darin, do you want to? Darin will take the.
Yeah, certainly.
Darin and Cecile. Cecile first, then Darin. Ladies first. Cecile.
Thank you. Very interesting question. First, for LGV, to my knowledge, there is no current research to detect specifically LGV in comparison to other urogenital genovars. And for instance, in France, the diagnosis of LGV is only performed at the French reference center. However, for gonorrhea, I agree with your comments. The problem of nucleic acid tests is that we cannot have the antimicrobial susceptibility of Gonococcus. But there is some research to develop nucleic acid tests to look at the same time for gonorrhea and its resistance to ESC or azithromycin, for instance. But to date, these tests are currently in development.
Darin, do you want to add anything?
No, that's...
Microphone 4. Jean-Michel.
I just want to give a word of caution about antibiotic prophylaxis for STIs. I think although we tested that in the Hypergay study, I think we have so far limited results, and we need to have more follow-up to make sure that we don't induce emergence of resistant bacteria, resistant syphilis, resistant chlamydia. So I think this is not a strategy that I would promote at all at this point. I think you made a good comment on, the need to foster vaccine development. You mentioned syphilis, gonorrhea, chlamydia. Also, there are groups working on the development of a chlamydia vaccine, and I really think that the development of vaccine plus doing a better job in terms of testing more frequently people at high risk, treating them earlier enough, and also increasing partner identification to treat the partners. I think that's also probably the right thing to do.
Yeah, thanks, Jean-Michel. Yes, please, number 4. That'll be the last question. We filled up all this time, which is amazing to me. So congratulate yourself.
Just snuck it in. Natasha Davis, lead clinician in South Africa for a safer conception service in the public health sector there. And I just wanted to say thank you to Scott for raising the issue around advocacy for women who are exposed to STIs and the impact on infertility, because we're seeing an awful lot of couples who are not conceiving. So they're well from the HIV side, but they've got this massive burden of undiagnosed STIs. And I think a lot of them are asymptomatic. And I'm using a syndromic approach where I know that I'm missing a huge number of them and I'm not treating people sufficiently. So I just wanted to ask the panel what their thoughts are around lower and middle and income countries and their access to affordable STI tests so that we can start treating people effectively.
Connie?
Well, I'm so glad you asked that question because I feel like there is kind of an acceptance in many circles that syndromic diagnosis is the best we can do. But I know, I mean, specifically when you were talking or asking your question, I thought it's a good opportunity to bring up that it's not as cheap as it needs to be, but at least it's a start that the Gene Expert platform can also be used for diagnosis of gonorrhea and chlamydia. I think that we need to push hard for cheaper nucleic acid-based tests because I'm focusing on Gene Expert because they are coming out with this very rapid technology where you can, and it's flexible. You could use it for HIV viral load and then also in the same machine test for gonorrhea, chlamydia, and so it's a great area. You know, encourage you since I think there are lots of Gene Expert machines in South Africa to be thinking about how do we integrate this into STI testing and show that it can be in places where the prevalence is high. It's probably cost effective, especially if we could drive the cost of each cartridge down. So keep pushing because I think we should not satisfy ourselves that syndromic treatment of STIs is adequate.
I think that was a great comment that we are able to do so much with HIV diagnostics and pole gene and a lot of other stuff, and we left all these other really important questions behind, including the burden of infertility that will only increase if, in fact, our STD rates are increasing. Let me say a couple of final words. Let me thank the panelists and Adele for leadership of this program. I think it was quite interesting. Let me thank the organizers, and especially Jean-Michel and his colleagues who's here in the audience for organizing this. And what I hear, Jean-Michel, is that you're supposed to go back to the program committee and say that there's got to be a way, based on Richard Hayes' cogent comments, of incorporating STDs aggressively and differently in a way that makes sense for the IAS in 2017. That's not just about PrEP apologista, more like what are we going to do going forward. So I think that was a great comment. Many people said it, so I want to thank you for being with us and for having this meeting. Thank you and goodbye.